Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live webinar. That is on a very important topic, that is cardio-rheumatology interface, recognizing silent threats. So, without any further delay, as we know that this is a very important topic, so we need someone who is expert. So, without further delay, I would like to invite our speaker for this webinar, none other than Professor Dr. Lieutenant General Ved Chaturvedi sir. And let me share some of the achievement of sir. Sir is Deputy Secretary General APLAR, former President of Indian Rheumatology Association, Delhi Rheumatology Association, and Professor Head of Department of Rheumatology at Government Research and Referral Hospital, New Delhi, and former Editor-in-Chief, Manual of Rheumatology, first rheumatologist in the country to use new therapy of arteritis called biologics since 2000, to establish MSK ultrasound medical and arthroscopy in 2003, and received the highest service award by President of India. And he is currently Professor of Rheumatology at Delhi Sir Ganga Ram Hospital, New Delhi, and he has published national 62 journals and international 18 and chapter in 42. Without any further delay, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed from here.
Thank you. Basically, I was in army, and after retirement, I'm working in this Gangaram hospital, and I did my DM in my subject, and after doing DM, I'm now happily retired from army as a lieutenant general, and I'm working in Gangaram hospital. So I'm a hardcore rheumatologist. So let me uh, just a minute. So this is my topic. That is the basically we all know about rheumatological conditions. You know about rheumatoid arthritis. You know so many other rheumatic fever. You know ankylosing spondylitis. But uh, m- probably not everybody knows that there are most of the diseases. The heart can also be involved, and that is a major concern. So my discussion will be cardiac manifestations in rheumatological conditions. So rheumatological conditions, common rheumatological condition, we all know first and foremost is rheumatoid arthritis. So rheumatoid arthritis, we all know it's a disease of joints. So if there's disease of joints, how does the heart involve and how serious is the issue? So that is the one problem. Another condition is SLE, lupus, which probably people know it's a multi-system disease. It's not only the joint, lungs are involved, kidneys are involved, heart is involved. So lupus is another. Ankylosing spondylitis, we all know ankylosing spondylitis and story of the aortic regurgitation, that we all know. So that can always, we know the connection of heart or blood vessels and the ankylosing spondylitis. But ankylosing spondylitis also can involve heart in many ways. Systemic sclerosis, that's why what is systemic sclerosis? Systemic sclerosis is thickening of the skin. So we always thought it is a, when we were youngster, we always thought it is a disease of skin. It's not only disease of skin. It is it is called systemic illness. So systemic illness means a lot of other systems, including heart, is involved. So many diseases involves the heart, and my today my brief is to speak about these illnesses. Uh, the how this topic came, that gradually people realize there is a excess rates of CVD diseases have been reported among patients with variety of inflammatory rheumatic diseases. So uh, people realize there's an inflammation, and inflammation can affect not only the joints, it in fact it can affect the heart also. And there is a CVD mortality and CVD mortality. Now, just a minute. Yeah. So This I've shown. Yeah. So basically, these rheumatic diseases, which are systemic in nature and they are autoimmune conditions, is autoimmune inflammation, and this can affect heart and the blood vessels. Cardiac involvement may be life threatening but may be asymptomatic also. So suppose I have a rheumatoid arthritis and I don't have any problem in the heart, but if you check my heart, you'll have maybe a double vessel disease, single vessel disease. How it came? Over a period of time, we learned that a lot of patients who are rheumatoid arthritis, if we do their testing, either by initially when we were young, that was ECG, echo, now by the angiography, then you realize, yes, there are a lot of young population, because rheumatoid arthritis is a disease of young, and they are the people who has this heart asymptomatic problem, and sometimes they become symptomatic and admits in the hospital. It causes significant morbidity and mortality in the rheumatology patient. As I told you, a lot of studies are available. Many studies are available which shows that in rheumatological condition there's an increased chances of cardiovascular disease involvement. So no doubt about it, for many years, almost last 50 years, we have shown that the cardiovascular involvement is common in rheumatological condition. It is because of the chronic systemic inflammation. So it's a inflammation. Inflammation is a ongoing inflammation, lifelong inflammation, and it escalates the atherosclerosis. So atherosclerosis and heart, we already know this relationship, and there's a premature atherosclerosis in the rheumatic diseases. So atherosclerosis is accelerated, and that is the main culprit. Yes, traditional risk factor everybody knows. The traditional risk factor for the cardiovascular diseases, the foremost is, we all know, we always discuss that he's a smoker, yeah, he will get one day a heart disease. So smoking is very well known as a traditional risk factor. Another risk factor we all know, diabetes. Another risk factor we know is the obesity. Another risk factor is family history, if somebody. So all these traditional risk factors and high cholesterol, we all know it. But there is a disease specific inflammation also. So if there is a rheumatoid arthritis, SLE, so basically there also, they are non-traditional severe risk factors. And coronary heart disease is common in rheumatoid arthritis and SLE. So today's, after my lecture, everybody should know that yes, coronary artery disease and other heart problems are common in rheumatoid arthritis, SLE, and other autoimmune diseases. The cytokines, I never wanted to start my talk with the cytokines, but it's like somebody knows about hormones. Now you are reading about thyroid, you know about thyroid hormones. So these cytokines, IL-1, IL-6, they are called pro-inflammatory cytokine. And so much research has been done. They are IL-1, IL-6, interferon, TNF, all these cytokines, they play a very major important part in the cardiovascular risk in inflammatory rheumatic diseases. So it's like a inflammation of the joint and inflammation of the blood vessel and inflammation of the heart. And the major culprit is these cytokines, basically IL-1 beta and IL-6. So this is very, very important. And we have seen there is a study which is very famous called Cantos study. This is a thrombosis outcome studies, which is a study basically is in this study they could prove that if you reduce the CRP, and CRP is a protein. What is a CRP? It's a protein made by liver, and this CRP is a risk factor, because the risk, because the CRP is a is basically shows the inflammation. It's an inflammatory marker. So more severe the CRP level is high, then there is a more risk factor. And if you reduce the IL-1 or IL-6, and the risk becomes less. So that is the how the suffices for this audience that cytokines are involved in the immune inflammation. They can inflame the joint, they can inflame the blood vessels, they can inflame the heart. So that is the, so this is to simplify, it's a oversimplification, that now even a third year student knows that cardiac valve is involved in one rheumatic disease, which is called as rheumatic fever. Now rheumatic fever and heart, we all know from hundreds of years. We grew, all of us, our generation, in fact, which was the stethoscope generation, we all grew with this rheumatic fever. Now, rheumatic fever is what? Actually, it is something like a reactive arthritis. So, what happens? There is a streptococcal infection in the throat, and the infection becomes all right, but the heart is involved, and the heart is involved because of the antibodies, and the traditionally valve are the mitral valve, tricuspid valve, and other valves are involved, and we all know about this very well. That he we always ask a history of rheumatic fever, and how we ask the history of rheumatic fever, the fleeting joint involvement, fleeting arthritis. So that is how the history is taken, and we used to present cases that he's a case of rheumatic heart disease. Over a period of time, we learned not the only the rheumatic fever, even rheumatoid arthritis can cause involvement of the valve. SLE can also involve the valve. Aortic ankylosing spondylitis can also cause. And there is another disease in rheumatology which is called antiphospholipid antibody syndrome. They can also call the heart valve involved. So if you have a case, a young patient who comes with mitral valve or a tricuspid valve involvement or a aortic valve, and you are not finding any other clue to explain, kindly look at, has he got rheumatoid arthritis? Has he got SLE? Has he got ankylosing spondylitis or antiphospholipid antibody syndrome? So that is one. Beside the traditional format which we know, rheumatic fever, the autoimmune diseases like RA, SLE, AS can also involve. Of course, all these diseases can involve the pericardium. The outside covering of the valve can also be involved. Now, patient is not going to come and say that my heart, my pericardium is involved. He will come with the vague pains, aches and pains. Look, I have little pain. So you might think that it is basically maybe some acidity because of the drugs he's taking. So retroesternal pain, but sometimes you're lucky, somebody has done an X-ray and find a pericardial effusion. Somebody has done an echo, yes, fine. Or your own sensitivity is high that yes, he may be having pericarditis. So you should have your own sensitivity. And earlier pericarditis we used to pick up by using stethoscope, by rub, and nowadays by the echo. So at least you can get an echo done to rule out the pericardium involvement or even myocardial involvement. So it's called myocarditis. Of course, myocarditis is more seen in lupus, but it can be there in rheumatoid arthritis also. Now, the all these layers of the heart can be involved in SLE, Churg-Strauss. Churg-Strauss is a vasculitis and rheumatoid arthritis, and all these. So most of the diseases can involve, but prototype you must remember. You should not forget, like SLE means pericardial involvement. It's called serositis. It is so common at least 30 to 40% that you must learn that yes, rheumatoid arthritis may involve, may not involve, but lupus involves heart. That's why the mortality of the lupus is so high. You must remember that. So that is an important message you must go with. Rheumatoid arthritis actually starts at a very young age, and it's a relentless inflammation. It is a lifelong inflammation, and it causes premature atherosclerosis and ischemic heart disease. They are more prone. Of course, it can involve the pericardium, myocardium, and even conduction defects. So, somebody, a rheumatoid arthritis patient, he comes and he has a conduction defect. So, don't get shocked yet. It can involve the they will come with chest pain in RA patient, which can mimics ISD. Can you switch off the AC? Uh, I had a patient, I still remember when I was young rheumatologist, this lady used to come with recurrent chest pain and she had rheumatoid arthritis. I always used to think probably she has some problem in the ribs or some problem in the. Till one day I found her in ICU and she had a frank pericardial effusion. So then my cardiologist colleague told me, okay, she has a pericardial effusion because of your disease, rheumatoid arthritis. That is what I also learned over a period. Yes, it's not only the books; it does happen. So that is how the SLE. Now SLE we all see, and as I said, commonest is pericarditis, pericardial effusion, serositis, almost 50%. So if I see say 2,000 patients in a year, 1,000 patient will have pericarditis. I may be missing the pericarditis. How? Because if I don't put a stethoscope and I have not seen a pericardial rub, if I don't know how to diagnose pericardial effusion, or I have not sent patient for a echo, so you must have a good sensitivity. It can also cause something like a endocardial involvement. So pericardial involvement, endocardial, and this endocardial involvement also has vegetations. Like you have infective causes, it's a non-infective causes, and it is called as Libman-Sec endocarditis because they were the people who described it. So Libman-Sec endocarditis, even if you don't remember this Libman-Sec word, SLE endocarditis, and it can cause myocarditis. So all things are involved: pericardial, endocardial, myocardial. And when myocardium is involved, then patient may have arrhythmias, and of course pulmonary artery. So they have a pulmonary hypertension, and how the patient present as a breathlessness on walking. So a lot of patients of SLE, a young girl, if she complains to a mother that I have breathlessness, so everybody say you are so young. Why should you have a breathlessness? You are young, and you don't have your hemoglobin is also okay, but you must not forget about the pulmonary hypertension, and you must diagnose by echo. So that is how the pulmonary hypertension is diagnosed, either by bedside if the P2 is loud. I still remember a patient who was admitted, and she had little discomfort in the chest, and I just sent for echo. I always thought maybe pericarditis something, but she had mitral vegetations. So I got scared because it may be infective endocarditis. But over a period of time, we learned that blood culture is negative, and the vegetations, and ultimately diagnosis of cardiologist was it is because of the lupus. It is vegetations are there. So the lupus can have Libman-Sec endocarditis also. Another disease which we know about is the systemic sclerosis. Now, systemic sclerosis is called as we call it the scleroderma. Now, scleroderma means derma means skin, sclero means thickening. So, thickened skin. It was called as scleroderma. Gradually, people realize it's not only skin, other organs are also involved. That's why it is called systemic. So the word is systemic sclerosis, means there is a fibrosis all over, not only in the skin, it is happening this fibrosis in the lung, fibrosis in the heart. So it can cause myocardial fibrosis also. And when myocardial fibrosis occurs, it can cause the conduction abnormalities. So they are very prone for conduction abnormality. I always tell people that systemic sclerosis has two basic pathology. One is fibrosis Another is a vasculopathy. So the microvascular coronary disease. So coronaries and the small blood vessels, especially the microvascular coronaries, are involved. So that can cause myocarditis also, and pulmonary hypertension, as it happens in lupus. In fact, systemic sclerosis has more chances of pulmonary hypertension. So if a patient of systemic sclerosis, how you diagnose systemic sclerosis? Systemic sclerosis is diagnosed because patient will say he has some skin thickness, so thickening of skin, that is a fibrosis. It can also present as a vasculopathy like Raynaud's, and some distal ulcers, and skin, and the lungs has ILD. But you should not forget about the heart. Heart can have fibrosis, and as a clinician, you cannot detect it. So you have to take help of cardiologist. Another is microvascular coronary disease, because coronaries, they supply to the heart, and those small blood vessels, their microvascular coronary arteries, can also be involved. And I just say pulmonary hypertension, and pulmonary hypertension is an important cause of the of the of the breathlessness, so, and mortality. So you must remember, and you must develop a high sensitivity towards the this pulmonary hypertension, both in lupus and both in systemic sclerosis. We had two patients, in fact, uh, with the diffuse cutaneous. In fact, one girl I lost also, very young girl, so I felt very bad. Probably I could not pick it up, but I was that time young. And CHF, that is the heart failure. And this girl used to come with all the classical features of basically the pedal edema, jugular veins, and so uh, systemic sclerosis, it can cause myocardial fibrosis and microvascular coronary disease. And the best person to pick it up is a cardiologist. So you should always take, as a rheumatologist or as a physician, if you're a patient of systemic sclerosis, and if you have a doubt that heart is involved, kindly take the help of a cardiologist, because all those gadgets have come, which is easy to pick them up. Of the ankylosing spondylitis is a very interesting story, because ankylosing spondylitis is a disease generally young males, and we have been taught from many years that they have aortic regurgitation. Now this everybody knows about aortic regurgitation story. Gradually we learn over a period of time that yes, there is an inflammation of the sacroiliac joint. Same inflammation is there in the aorta also, because the aorta also has a type 2 collagen, so that is known. And this aorta can also, this involves the lower part of the heart, the an aortitis and myocarditis, and they can cause conduction abnormalities, AV block. And I still remember a young male who had ankylosing spondylitis. He was a youngster, about 32, and he used to have repeated syncope attack. And I always thought it is because of the uh, cervical this thing involvement. The why should have a repeated syncopal attack. And gradually, when a ECG was done, we found out that he is having the AV block. So that is the AV block story is there. So ankylosing spondylitis and the AV block. Now, another disease which probably most of us now, young physicians, are aware of, but maybe there may be some people who may not be knowing about this disease. This was the first disease which name, like rheumatoid arthritis and lupus. Now, lupus is not called as ANA disease, but this was one disease which was named after antibody. So this was called as this disease called as antiphospholipid antibody syndrome. So there is an antibody in these patients. There is an antibody present in the blood, and the antibody's name is antiphospholipid antibody. Just remember this. And the biggest issue is as it's a prothrombotic state. So there is more thrombosis. So that is how it is. So arterial thrombosis or a venous thrombosis. But these patients also have many other issues like valvular thickening, valvular disease, regurgitation, pulmonary hypertension, and I was in Calcutta at that time when this lady came with recurrent miscarriages. Now, miscarriages also because of thrombosis of the placenta. And this lady had 11 abortions, and then she came and with a stroke, and there was a valve thickening also. So that was the first case I learned that antiphospholipid antibody syndrome can also involve the heart. Beside the thrombosis, which is very well known, it can cause the involvement of the psoriasis. Now, psoriasis, even I learned quite late about psoriasis. I always thought psoriasis means naturally a psoriasis means a skin disease. In last 10 years, so much research was done on psoriasis, especially the cytokines like IL-17, IL-23, that we learned that psoriasis has a strong association with the hypertension, with the obesity, with atherosclerosis, with the heart failure. So it's a metabolic disease. Now, metabolic disease has a strong association with the atherosclerosis, obesity, ischemic heart disease, heart failure, arrhythmias, and now, whenever some ladies admitted in ICU with the MI, and you'll be surprised that almost I've become so successful in almost about 2-3%. Suppose 100 ladies are admitted with myocardial infarction in a month. And if I can tell you, I always ask, do you have psoriasis? And at least 2 to 3% people have psoriasis. So psoriasis has a very strong association with the heart, and that we have to learn as a physician that the accelerated atherosclerosis and psoriasis, it is a very very important things to remember. Polymyositis, dermatomyositis is basically it is a muscle disease which is autoimmune. It is a muscle and skin disease. It is called dermatomyositis. It's a very very, it's not a, it's a, though it's a rare disease, but rare means even hospital, bigger hospitals like today I'm working Gangaram Hospital. Even Gangaram Hospital doesn't get more than maybe a 15 cases in a year. Same must be AIMS and other hospitals which we have. And these patients, if the heart is involved, they have a poor prognosis, and there is an antibody association of the, which I don't want to teach you the polymyositis, but there's a cardiac involvement in the if you have a patient of polymyositis. The polymyositis generally presents as what? There's a Bowen-Peter criteria where they will present as a proximal muscle weakness. And how will, as a clinician, you will pick up the proximal muscle weakness? In the OPD, you just tell patient, do you feel difficulty in getting up from the sitting posture? Yes, doctor. For last 1 or 2 months, I am finding so difficult to get up from the commode or getting up from the from in the prayer in the mandir. So proximal muscle weakness is one. Then CPK is high. That is number two. CPK is an enzyme which is comes from the muscle. So CPK is high. Then if you do EMG, the EMG shows the myopathic pattern, and muscle biopsy can diagnose it. Now even MRI can MRI of the muscles can diagnose. So that is how you diagnose polymyositis. And if the classical skin lesions are there, like heliotrope and the Gotton's rash, then you can diagnose polymyositis and dermatomyositis. So once you have diagnosed polymyositis, dermatomyositis, and you must develop the sensitivity that they can have arrhythmias, they can have myocarditis. there will suddenly you lose a patient of a myocarditis, and everybody will blame you that he's a muscle disease, you could not pick up the heart, because so heart is also involved. So that is very important, and it is a poor prognostic sign in the dermatomyositis or polymyositis if heart is involved. Behcet's disease, rarely, extremely rare in this country. It is more common in the Silk Route, where people present as a oral ulcers and genital ulcers and vasculitis and and the veins inflammation. They also have pericarditis and intracardiac thrombus and aneurysm and coronary arteritis, and they are the people who present as a MI in young patients. So just remember one thing, that traditional risk factor like smoking, obesity, diabetes, they you are more prone. Yes, definitely it makes you prone for heart disease and coronary artery disease, but these patients will present at the age of 50, 60, 70. But if suddenly you have a patient who's about 30-year-old and he's admitted with the myocardial infarction, you must look for some other non-traditional causes like autoimmune diseases, some diseases which are genetic, I still remember one of my relative. He developed he developed syncope, and he rang me up. Then I said, you don't have anything, you don't worry, you are young. But then he went to a doctor and he saw the ECG, which was frightful, and he got a TMT, and he said, you have a very severe heart problem. He came to Delhi, and angiography revealed triple vessel disease. And triple vessel disease in a young age of 25, 26 was shocking to me, at least because I am not a cardiologist, but that is the first time I saw. And then I discussed with the cardiologist. He told me it is because of the his thin coronaries. They are genetically thin. So there are a lot of individuals. So beside he was not a smoker. He was not obese. His triglycerides were normal. So there are traditional risk factor. There are non-traditional risk factor. Autoimmune diseases comes as a non-traditional factor for the heart diseases, and the biggest problem is a lifelong inflammation, and this inflammation is driven by the cytokines, pro-inflammatory cytokines, and that is a cause of the heart problem. So they can have coronary arteritis and the MI in young patient. And we have seen one Behcet's at least who had when a he was having breathlessness and discomfort, and to my surprise, when the echo was done, he had a big thrombus in the heart. So that they have a thrombus is in the vein, they can have thrombosis in the heart also, and this thrombus is because of the endocarditis. So endocardial inflammation, and then the as to summarize of the issues, must remember SLE. SLE remains on the forefront, which can present as a pericarditis like a chest pain. They can present as endocarditis like Libman-Sick endocarditis. They can present as arrhythmias. Rheumatoid arthritis is they can make you prone for atherosclerosis and pericarditis. Systemic sclerosis, as I said, the name itself is sclerosis. They can cause fibrosis in the heart also, and conduction blocks. Ankylosing spondylitis, they can present as inflammation not only spine but also in the aorta and AV block. While antiphospholipid antibody syndrome, which is hallmark of is a thrombosis, they can present as a valvular disease. While psoriatic arthritis, it's a metabolic disease. They can present as a cardiac failure or ischemic heart disease. And polymyositis, dermatomyositis, they can present as a myocarditis and arrhythmia as well. Behcet's vasculitis can present as endocardiac thrombosis or aneurysm. So investigation depends on what you want to see by ECG, echo, cardiac MRI, and biomarkers like troponin, BNP, and CT angiography for vascular involvement, and management by aggressive control of systemic inflammation. So, if you control the primary disease, then you can have a control of the disease. Cardiovascular risk modification, if somebody is rheumatoid arthritis and is smoker also, then you can say, so that is another thing. Obesity, and so you treat them well and treat the risk, traditional risk factors also. And disease immune specific immunosuppressive, like there are very good studies are available for hydroxychloroquine, even for leflunomide, that they are a very cardiac protector. Not many people know it, that if you control the inflammation of the disease like arthritis or lupus with the uh, with the with the hydroxychloroquine or chloroquine, then you are even preventing the heart attack also. A lot of people think it is a cardiac toxic drug. And monitoring for cardiac signs, so it is very very important as a good physician which we are, that whether heart is involved or not, we should have a good sensitivity to conclude cardiac involvement is common in rheumatological condition, can be asymptomatic or can be severe. Early detection improves the outcome. Rheumatologists must closely monitor the cardiovascular health closely. Thank you so much. Thanks.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yeah, we can take about 5 minutes, five to seven
Yes,
minutes.
yes, sir.
Yeah.
We will take couple of questions, sir. First
Yeah.
question is, sir, how to balance immunosuppressive therapy in cardiovascular safety, sir? What's your point of view on that?
Well, the not many people understand that the basically we monitor we how we titrate the immunosuppressive drugs is the treat to target. If you have target, like what is the target in rheumatoid arthritis? Target is the basically you have made a score like DAS or some score like how you control the BP. You say BP is 120 by 80, that BP, any BP less than 140 80 is good. Same is in rheumatoid arthritis, that you have a some of the you have chosen some parameters like pain, swelling, ESR, CRP, and then you have made a score, and you can call it DAS score. There are a lot of other scores like for lupus there is SLEDAI and other scores, and you have made that you control these parameters, so you control the immune inflammation. So even it can prevent the heart attack also, because if you prevent the immune inflammation, your heart, it is a preventive factor for the heart, as I said. So heart disease and rheumatic disease both. So if you control rheumatic diseases, your heart disease also controlled.
Thank you so much, sir, for answering this question, sir. We will take one last question for today's webinar. Sir, what are the key unmet needs in rheumatology research that clinicians should be aware of, sir?
Well, probably the most unmet need is the cardiologists are busy in the cardiac lab, and rheumatologists are busy because our problem is pain. Any specialty which is disease dealing with the pain, it's a painful specialty, because you have to listen to the patient, because patient always feel that probably doctors have not heard him. So my first advice to all the doctors who are dealing with the rheumatological condition is they should be good listener, even if they don't understand. So you must listen, that is number one. Once you have listened to them, you must realize it is not only the joint problem, it's a systemic inflammation. Now, systemic inflammation means all systems are involved, including heart. So, your lung is involved, your heart is involved. So, you should develop sensitivity. A doctor should develop sensitivity that yes, he also feels that heart may be involved. If he develops the sensitivity, then only next step can be done. So there's a poor research. Why it is a poor research? Because the cardiologists also don't understand, and the probably the rheumatologists also don't understand. There is such a close association between rheumatologists and cardiologists because of the immune inflammation which affects the every part of the body including heart. So that sensitivity has to be developed. Once you develop the sensitivity, then you develop the marker. There's a marker. A day will come where some marker will be developed where we know this rheumatoid arthritis has this marker. And if this marker is present, probably his heart is going to be involved. That day has not come. Probably it will take time, but it will come one
Yes,
day.
sir.
Thank you so much. Thanks.
Thank you so much, sir, for answering this question, sir. As I can't see there is a further question, sir. I hope, sir, you have done justice to this topic and able to solve all the queries related to this topic. Sir, as there is no
Thank
more
you.
questions, with all your permission, shall we conclude this session for today?
Thank you so much. Thanks.
Welcome, sir,
Thanks.
and we would like to see you in future also, sir. Till then, take care of yourself. And, sir, Jai
Thanks.
Hind. Thank you, sir.
Yeah. Thanks.